It is my pleasure to introduce our final two speakers here. Just to start, our final primary speaker is Dr. David Christiani, a professor of medicine at the Harvard Medical School and a physician in the pulmonary and critical care unit at Mass Gen. He also holds the Elkan Blout Professorship of Environmental Genetics at the Harvard T.H. Chan School of Public Health and serves as the director of the Harvard ERC for Occupational Health and Safety. Dr. Christiani earned his MD from Tufts University and completed both his Master of Science and Master of Public Health at the Harvard T.H. Chan School of Public Health. He completed his postgraduate medical training at Boston City Hospital and at Mass Gen, and is board certified in internal medicine, pulmonary medicine, and occupational and environmental medicine. He's a fellow of both the American Thoracic Society and the American College of Preventive Medicine. Dr. Christiani's research focuses on the interaction between human genes and environmental exposures, with a particular emphasis on molecular epidemiology, pollutant-related disease, and the development of acute and chronic pulmonary disease and cancer. He served on numerous national advisory roles, including appointment by President Obama to the National Cancer Advisory Board, and has co-authored or co-authored more than 1,000 peer-reviewed publications. We're very grateful as well to conclude this webinar series with his presentation featuring a case introduction on smoke inhalation by our very own Dr. Susan Upham, part of our education committee at NECOEM. Dr. Upham is a board-certified occupational medicine physician in Maine and provides general occupational medicine care. And so I will turn it over to her as well as Dr. Christiani to take us home.
Okay, well, thank you, everyone, and good morning. I'm just going to take a few minutes and go over a case that I had referred to Dr. Christiani, and it introduces some of the real-life problems that can develop with occupational exposure to smoke. So let's start off and talk about a little bit of a background, or give a little bit of a background of our patient. She was a 30-year-old female police officer, and this was during 2020, during the pandemic. And overall, she was a really healthy lady. She had no chronic or recurrent medical conditions except migraines. She had recently started treatment for a sinus infection, which was improving. She was a former smoker. She had smoked about a year, 2 cigarettes a day, and had last smoked 10 years prior. Of significance was that she was a competitive athlete, and she engaged in these incredibly intense bodybuilding and cardiac workouts on a very regular basis. And that becomes more of a concern for her later on as we deal with this case. Next slide. So what happened? She and her colleagues were the first public health folks, public emergency folks to arrive at a burning nursing home. And this was before firefighters arrived. And they entered the building and attempted to evacuate it, but they were not using respiratory protection. And they went into hallways that were really filled with very, very thick smoke. And it's not exactly clear how long she was in the facility, but it really was not very long, maybe 5 minutes, maybe 10 minutes maximum. She left there and she developed symptoms of a non-productive cough. She continued her exercise regimen. And she was noticing some shortness of breath, chest heaviness, and wheezing with her exercise workouts. But things were not so severe that she didn't even go for treatment on the first day. In fact, she showed up at our office about 5 days later, and her main complaint at that time, again, was the shortness of breath and these other symptoms. And her examination was fairly unremarkable. O2 sat was normal, lung exam was normal, color was normal. We did do a chest x-ray, PFT, they were normal. And she was prescribed albuterol and was referred to our local pulmonology group, who were actually able to see her fairly promptly, which was really great. They thought she might have had a heart murmur, and they diagnosed reactive airways disease and added Pulmicort to her medication regimen. But she really wasn't improving, and a few weeks went by, and they finally gave her a course of oral prednisone. They did order an echocardiogram, which showed a little dilation of her right ventricle, but no valvular disease. And from our perspective, we recommended administrative type work. At the time, we were very worried about a person with lung disease getting COVID, and we didn't want her really public facing. So we suggested she not do community police work at the time. However, her employer opted to just remove her from work. We did later do a chest CT scan, which was normal. Next slide. So what was her progress? She continued to have waxing and waning symptoms, and even 4 months later, she was having good days and bad days. Good days would involve minor shortness of breath, but bad days, which were actually 3 to 4 days a week, she would become very short of breath after her mega exercises, and it could take her up to 30 minutes to resolve those symptoms after she rested. She also started to report some difficulty with swallowing and was complaining of throat clearing more frequently. She wasn't wheezing. She remained on her albuterol and Pulmicort for a while, and then I believe pulmonology switched over to Advair. And at that point, she was getting pretty frustrated. And so at that point, wanted a second opinion, and I referred her to Dr. Christiani. Before that, however, she did undergo a few other evaluations. She was referred to ENT, who did a laryngoscopy, and she had some nasal turbinate edema, but also edema and redness of her vocal cord region. And they thought she had a combination of things going on, some allergic rhinitis, probably some laryngopharyngeal reflux, which they thought could have caused the throat clearing, and some non-specific shortness of breath. And they thought she had some vocal cord dysfunction, probably impacted by the smoke exposure. They added famotidine and omeprazole to her regimen of treatment, sent her to speech pathology, who really felt she did have a vocal cord dysfunction, and they recommended some therapy, which she attended. When Dr. Christiani saw her, he had suggested that at some point a methacholine challenge test was done. Honestly, it was never done because around that time it was COVID and most people weren't doing them, so she ended up not having one. Next slide. So what was her progress? She was really relieved by her assessment with Dr. Christiani, who confirmed smoke inhalation-induced asthma. She remained on her medications, but eventually got off the cortisone-based ones and focused mainly on albuterol. We did finally, around that time, release her to regular duty. Dr. Christiani felt that that was reasonable. And by 9 months of exposure, she had a flare-up. After all of this, she got herself into an exposure situation where there was variable smoke exposure from burning ammunition boxes. And so she had a flare-up of her respiratory complaints. I gave her some prednisone. That resolved that. But by about a year, she was overall improved, and she was stable, but she still had intermittent shortness of breath a couple of times a week. She still relied on using her albuterol inhaler. And she continued these very aggressive workouts 4 to 5 times a week. And she expressed disappointment because she felt that she was still limited and not as good as she was compared to pre-exposure. So with that, as you can see, these exposures, even if they're brief, can have severe ramifications on a person and even cause some long-term residual complaints. So with that, I'd like to turn over the presentation to Dr. Christiani to talk about smoke inhalation, evaluation, treatment, and management.
Thank you, Susan, and thanks,
You're
Kevin, for the
welcome.
introduction. So let me pull this up. All right. Get to present. Everybody can see that okay?
Yes.
Yes.
Okay. Oh, okay. I have to do something because I can't see it okay. Where are you? Okay, hang on a second. Here we go.
Need to place it. Yeah, there we go.
Okay.
Perfect.
I get rid of the bar. Okay, thank you again for the kind introduction, and Susan for a great presentation of that case. So, and this is great to see you all. A lot of old faces and new faces. Great panel. So I'm going to disclose that I have done expert testimony and impartial medical exams for compensation cases in the region. So what is smoke inhalation, which is a topic that Susan wanted me to talk about. We'll loop back to asthma, of course, but let's talk about smoke. So, of course, it is a major cause of morbidity and mortality in fires. And We know that injury can occur with or without cutaneous burns, and the effects range from quite mild irritation to irritant-induced bronchospasm, asthma, and then to full-blown adult respiratory distress syndrome, acute respiratory distress syndrome with pulmonary edema and death. And the latter can be delayed, as most of us know from our OCMED and emergency room training, that you can have a 24-hour delay or so from smoke inhalation to the presence of pulmonary edema. So what is smoke? What's the exposure? We're an exposure-oriented audience of healthcare providers. So there are three major components, toxicological components that are potentially injurious to airways. We'll focus mostly, of course, on airways today, but as I mentioned before, the lower respiratory tract and alveoli can be affected. So one is thermal injury. That's the obvious, right? Oropharynx, larynx, and usually presenting to emergency room and with visual or with upper scope, pretty well and easy to document. Then there are chemical irritants, a complex mixture of particulates, aldehydes, sulfur dioxide, oxides of nitrogen, a real mix, depending on what's burning, what temperature it's burning at. And then there are straight toxic gases such as CO and the cyanide, depending on the base material being burned. So it's a very complex exposure, reasonable to assume virtually all of it is potentially lethal and hazardous, which is why the right people need to respond at the right time and why our firefighter first responders are trained the way they are. And as this case illustrates, that's not so true of other first responders like police and civilians. So what is the nature of the injury here? So as opposed to, of course, allergic phenomenon, we're talking about an airway inflammation that can be quite intense with mucosal edema, bronchospasm, infiltration of polymorphonuclear cells into the area. And in addition, impaired mucociliary clearance with soot and debris coming up, with copious mucus production that can lead to plugging and airway obstruction, particularly in the lower airways. And of course, alveolar damage in the more extreme cases that can lead to pulmonary edema. The hypoxemia seen in this condition is from VQ mismatch. Once pulmonary edema takes place, there's also, of course, a considerable shunting, but mainly we're talking about VQ mismatch. So the manifestations can be early or delayed. So early, pretty straightforward: cough, hoarseness, wheezing, eye, nose, and throat irritation, and dyspnea, and usually, in most cases, mild hypoxemia. If it's severe, of course, it's an emergency situation. Individuals may be candidates for hyperbaric oxygen. In the delayed cases, it's deteriorating oxygenation over a day or more, the onset of pulmonary edema with severe dyspnea, and can lead to full-blown ARDS with stiff lungs and requiring mechanical ventilation. So what are the late effects of smoke inhalation as relevant to today's case? Since she obviously didn't suffer thermal injuries or have a delayed pulmonary edema response, what are the more delayed and late effects? Well, complications can develop weeks or months to years after exposure. The typical reactive airways that can occur with high-dose irritant exposures usually happens immediately within 24 hours. At least some symptoms do, if not the full-blown syndrome. And these can occur even after apparent recovery, some months after the episode, as in this case. It tends to be under-recognized, and it's driven really by persistent inflammation and some airway remodeling, which is permanent changes in the airway that occur with asthma and chronic bronchitis, permanent to semi-permanent. So what is the pathophysiology? Well, it's inflammation, inflammation, inflammation. But I think the thing to think about here, as opposed to our general view of, say, asthmatic conditions, is we're talking about injury. This is epithelial injury with abnormal repair rather than infiltration of allergic cells, eosinophils, sensitization, re-exposure, things like it. It's a totally different mechanism, and our mindset should think more like injury, basically, which is why a single acute episode can lead to long-term effects rather than chronic re-exposures. There can be subepithelial fibrosis as part of that abnormal repair and remodeling. There's commonly small airway obstruction with mucus and with thickening of the airways and bronchiolitis, including a certain degree of either bronchiolitis obliterans or more commonly something called constrictive bronchiolitis. Pathologists like to argue about these things. The upshot for us is pretty much the same clinically. And of course, if the parenchyma is involved, there can be reduced gas exchange area. So the chronic disease that we can see after smoke, repeated or even single acute. We're concerned about this, of course, with firefighters and with the fires out west, where people repeatedly getting exposed, not able to protect themselves with PPE for so many hours a day, and can start to develop chronic problems like a bronchiolitis obliterans with fixed obstruction that will not respond to treatment. The so-called RADS, reactive airways dysfunction syndrome, was described by Stuart Brooks back in 1985 in an article in Chest, a case series that was really well detailed. But the consensus since then by American Thoracic Society, Europeans, and the ACCP is that we don't use that term anymore. Basically, this is irritant asthma. It's a variant of asthma. And now we can use reactive airways, of course, which is a hallmark of all asthmas, plural. But the idea of RADS as a distinct syndrome is no longer considered clinically the right way to characterize it. It's asthma, it just happens to be caused by irritants rather than allergens. And these symptoms will be chronic cough, wheeze, dyspnea, just like any lung disease, not just any other asthma. The symptoms can be nonspecific. They can start to get specific, however, where someone tells you, I only get it when I exercise. That means I've developed exercise-induced asthma. Or one of the triggers is cold air, which is very common in all asthma, whether it's allergic or non-allergic. And of course, you exercise in cold air. It's a pretty good challenge test. If we're in controlled circumstances, inhalation of frigid air with something like exercise is just as predictive as methacholine, but it's just not easy to control for all the variables. The parenchymal sequela can be quite serious. It's not the case here, where the CT scan did not show pulmonary fibrosis and reduced DLCO, but that can lead to exertional hypoxemia, which of course is not exertional asthma, but it's exertional drop in oxygen saturation. And these folks can be a significant infection susceptibility. It's actually true for the asthma conditions too. So the vaccines have to be kept up to date, as well as early aggressive treatment of pulmonary infections. So what about imaging? Well, again, in this case, we can come back to, but PFTs, usually show obstruction with a bronchodilator response if the person is active when you see them, but it actually can also show restriction depending on how long it's been and how much remodeling is going on in the lung. Reduced DLCO is not common in asthma. In fact, it's usually quite normal, even a bit high. But again, it depends on how much damage and where it is in the lower respiratory tract. In bronchiolitis obliterans, we no longer see a bronchodilator response, so there may not be parenchymal fibrosis. The symptoms seem to be bronchospastic, but they're not going to respond. The airways are too small, usually affecting airways 2 millimeters or smaller, which is actually a very big area that we need in the lung for proper gas exchange, but too small to have any muscular walls that will respond to typical bronchodilators. And then in the lower respiratory tract situation, including bronchiolitis obliterans and alveolar changes, they'll see something called mosaic attenuation, air trapping when they do the exhalation version of the CT, and some bronchial wall thickening. And that's what you see here. So this is with inspiration on the left and then an expiratory CT scan. And there's some really obvious, and this is no longer small airways, these are big airways. You can see thickening around the airways. And there may even be mucus plugging. Let me see. There might be some mucus plugging right there, but you can see thickening in the airways. And on expiration, those airways are still open and thickened, and air is trapped. There should be better emptying on expiration. So those are the more serious. We're moving from airway irritation and inflammation that will resolve to airway inflammation and bronchospasm that will be an asthma syndrome, to lower respiratory tract bronchiolitis obliterans, and even some pulmonary fibrosis, excluding ARDS as far as the acute picture. So all of these can happen as a chronic sequela of smoke. So what do we do? And well, one, of course, is long-term follow-up is very important, as it was done in this case. Serial PFTs are important because a young person like this may actually start out with pretty normal, meaning predicted normal range PFTs, but over time, you might see continued improvement because we don't have baseline. If we have baseline PFTs, you may well have seen in a young person a significant decline, but still within normal limits. Then you still need to follow them, and hopefully there'll be some improvement. So the idea that someone might have normal PFTs at baseline, who's essentially a non-smoker with an acute exposure, otherwise in excellent shape, is not at all surprising for an irritant asthma type syndrome. The HRCT for persistent symptoms would be indicated as here. It doesn't have to be the first thing that's done, but it was done because of persistent symptoms. And of course, like Susan's case, symptom-directed therapy, and when indicated, pulmonary rehab could be helpful. So let's then briefly review asthma again in its various iterations and how this comes up. So we know most of the asthma in the workplace that's been described in the literature tends to focus on sensitizing agents. That is, exposures with latency periods. There are over 250 or so. It's hard to remember all of them, but we can certainly remember classes such as a high molecular weight group, protein, and they're animal dander and large protein-derived, plant-derived proteins that people become sensitized to that we're all familiar with, protein polysaccharides. Then there's the low molecular weight compounds. These can be inorganic compounds like elemental, platinum, nickel, but also complex synthetics like epoxy resins, isocyanates. Glutaraldehyde used in the hospital setting, as we know, it's a formaldehyde-like substance. Nickel and platinum and jewelry and electronics industry. Plicatic acid's on the list, but that's actually in Western red cedar. It's not commonly seen here in the East, but that's the causal agent in Western red cedar asthma. And then there's a group we're talking about here, is irritants. They really are a distinct category. Various acids, various bases, and smoke, the generic smoke that we're talking about. So the phenotypes of work-related asthma, and this was from a chest supplement done some years ago, maybe 2008, with a consensus statement, is to break these up into immunologic and non-immunologic. Latency period, things we remember a lot from med school and practice, the sensitizing agents, where weeks to years of exposure are needed to develop this. And most allergists will tell you that it takes people who are going to become sensitized to a compound like, animal dander in the lab or something. Most of the time it'll take place in the first 24 months. It won't take place, 10 to 20 years later. So it'll be weeks to maybe up to about 24 months. That's with, there may be skin tests well before then, but the symptoms of asthma may not occur right away, but they will occur at some point early on in the career. These are immunologically mediated, primarily high molecular weight, and there are type 1 IgE response, but they could also be non-IgE mediated in the low molecular weight categories. Some of them are haptenic. They can glom onto proteins, and then you have IgG mechanism of sensitization. It's still immediate hypersensitization, but it's a different mechanism. Then you could also have T cell, of course, which is a non-immediate hypersensitivity, which is a very important role in asthma, and especially a Th2 response. Then there's the non-immunologic that we're talking about today. No latency period required, can occur after a single high exposure or multiple moderate exposures. It doesn't occur really with multiple really low levels of exposure. I think, and you see that, you wonder that if asthma is actually present, that it might be uncovering latent asthma that's been there. But there's usually significant, I realize that's a weird term, but it's usually obviously very high or at least moderately high levels of exposure if someone's starting out very normal. So it's less common in terms of our estimates from population studies. About 7% of work-related asthma is considered the irritant form. Now, again, I'm not including well-established childhood asthma where someone's very stable and they have irritants as a trigger in the workplace, kind of a non-specific trigger. That could even be like drywall dust or something. That's different. That's very, very common. We see it all the time, but it's not. I'm talking about de novo asthma in this case. So this can occur in response to either sensitizers or irritants if the sensitizer is present in high enough quantities to be irritating. Why do I say that? Because isocyanates are both sensitizers and irritants. So remember the Bhopal disaster, methyl diisocyanate years ago in India, and then there was another explosion in West Virginia. Isocyanates, of course, are sensitizers, but the immediate morbidity and mortality from those things were from the high irritant concentrations of the isocyanates causing pulmonary edema, and for a lot of people, airways disease kind of immediately. Again, there's not great evidence for what we would consider low-level chronic irritant exposures, household cleaning exposures and things that are used in lower quantities, but there's plenty of evidence for that being a trigger to known asthmatics. And as you know, they mostly, especially if they had childhood asthma, they know how to avoid triggers and manage their lives appropriately. There was controversy about whether RADS is a subset of work-related asthma, meaning are the RAD cases that previously described uncovering existing asthma that just wasn't diagnosed. Hard to prove one way or the other since we don't have baseline information on people that include things like a methacholine or a PFT. The history is important though. If someone's gotten to adulthood and played sports in high school and they all had their usual bouts of flu and don't have asthma, and they're now sitting in front of you with asthma after these exposures, you use your clinical common sense. There's no documentation of prior asthma. It's hard to say that their irritant-induced asthma somehow uncovered something that was there all along. This is from Susan Tarlow's review in the New England Journal of irritant-induced occupational asthma. It's an outstanding review. She really just focuses a lot on the original description by Brooks and what needed to be modified. She now includes, and I can't remember if this is included in the ATS consensus document, she includes that if someone had a history of new onset asthma or had childhood asthma that was stable for many years and then recurs, that counts as a criteria for irritant asthma, adult irritant asthma, with the trigger being the workplace cause. Then she also goes talks about high-level exposure. Symptoms usually begin less than 24 hours, but can begin in some cases up to several days, but not months or years. And the exposures tend to occur with highly irritating gases, dust, or fumes. And she included the note of World Trade Center collapse because that experience of first responders in many pulmonary medicine people's minds really started to put a few things on the agenda that weren't there before, mainly what does nuisance dust mean? If it's high enough exposure, is there really any such thing as a benign nuisance dust? Why do I say that? Because the causative factors for the first responders airways obstruction, which included bronchiolitis in some cases and asthma in other cases with positive methacholine and accelerated decline after 6 years, was all due to Portland cement. High dose exposure to Portland cement in the World Trade Center after the World Trade Center attacks with pHs above 8. That dust, as you all know on this line, is not regulated by OSHA other than a nuisance dust, which is like 15 milligrams per cubic meter, which I think we would all agree is pretty high. You can't see across the room. So it really raises a question of something that seemingly is benign. And I've mixed Portland cement myself to do some work in a house sometimes. In low-level exposure, it may not be an issue, but in high enough exposures, it can lead to permanent airway damage. And the feeling is it's because of, we always think about acid in the airways from GERD and things like that, but this is high pH above 8. So the airways are not happy about extremes of pH, including alkaline. And it doesn't have to be lye. This is dust, but it's pH above 8, very irritating to the airways. And now, as we know, we don't have a new OSHA standard on that, but we should be very suspect of having workplace exposures for dust that could be like Portland cement saying, well, we're below the OSHA standard, and the IH says, and they have levels in the milligrams per cubic meter for a long time. You should be very skeptical. Which also now includes previous airways disease associated with smoking, or atopy may be difficult to rule out for sure. So again, the mechanisms are different. On the left side, we see the current understanding of allergic asthma, sensitized-induced asthma, where the T lymphocyte, the antigen-producing cells, the dendritic cells, and the T lymphocyte are key to either type 1 or type 2 response, predominant eosinophil or non-eosinophil response. Great. But we're talking about over here something completely different, with irritant-induced asthma, epithelial damage, oxidative stress, even get denudation. The epithelium will denude, fluff off, subepithelial damage. And the key is in infiltration of neutrophils. But part of the key here is, of course, some people will just recover and go about their business and not develop asthma. But what happens, the current feeling is with animal and some human observations is it's the healing phase, and you get complete re-epithelialization unless there's scarring there, but there's an altered threshold of airway responsivity upon healing. There's your bronchial hyperresponsiveness. And so you can have the whole complex of asthma: bronchial hyperresponsiveness, mucus hypersecretion, and resonant inflammation, non-eosinophilic in nature. So how do you diagnose it? Well, confirm the presence of asthma. The sine qua non is reactive airways, pre and post bronchodilator spirometry, or if necessary, a methacholine challenge, which is highly sensitive, but is actually low specificity, telling you the cause of the asthma. But and you could have negative methacholines, and people still have asthma. That's why the specificity is lower than the sensitivity. There's also a timing thing, and the occupational setting presents even more challenge. There's a case, there was a case series out of Cincinnati. I think it was the Bernstein brothers back in the day. Small study in JOEM, but I thought it was quite interesting. And they were allergists and occupational allergists. There's a group of 4 workers who had a very strong history of asthma developing to a couple of compounds of work. It wasn't all the same compound, but they were all known sensitizers. It took a while for them to get an appointment in clinic to see an occupational specialist. So when they were seen in clinic, the methacholine tests were negative. So they were sent back to work because the PFTs were normal and there was negative methacholine. Then they presented back with symptoms, and all 4 were positive after they were re-exposed. And so that's a case of a sensitizer issue. I wouldn't expect that quite of the kind of case we're seeing today, but it's something to keep in mind. So the specificity of those particular individuals was to a particular compound they were sensitized to in the workplace, and outside it did quite well, but they were going to be told they had no occupational asthma, and that would have been a spurious diagnosis because after 4 months not being exposed, they had decent airway function, and other triggers weren't bothering them. We now know that even in both irritant asthma and in sensitizer asthma, at least 50% of people who develop those at the workplace go on to have chronic asthma. Specific challenge tests we don't do in the US. It's unsafe. People have to be hospitalized. That's where you're using the agent or agents. We would never do that with smoke because of obvious reasons, and carbon monoxide and the complex exposure. So the PFTs could be normal or it could be obstructive. If it's normal and the person is clearly symptomatic, you can proceed to a methacholine challenge, which we're now have started to do post-pandemic. You do not use specific agents. It's very rare that these days in complex exposures that you're going to be able to identify that anyway, and it can be quite risky. Pre and post shift spirometry is still an acceptable way. If you think someone's healthy enough to go to work, but they're having trouble at work, or at least some days at work, you do the pre and post. 12% would be enough to be positive. This is an outdated slide. And suspect for sure on the day shift, 10% would be suspect, since daytime diurnal variation in PFTs, the daytime you usually gain a little during the day shift, neutral on the second shift, and you decline around the third shift with normal diurnal variation. So I see a 10% shift across the day shift. I would say that's quite suspect. serial peak flow monitoring. It's cheap and easy to do, and it's used to treat asthmatics, but you can use it as a diagnostic tool. So you confirm the presence of asthma. The key here is establish that relationship with work. Symptom periodicity. When is, what bothers you, what doesn't, when does it come on, when does it go off? I can't, it's less so with irritant asthma, but I've had a number of cases where I've had pulmonary colleagues send people in and say, geez, this is a strong history of asthma and it's periodic, but I don't know if it's due to work because they're getting symptoms only at the end of the day or sometimes when they're driving home or making supper. So maybe it's something at home, but their allergy tests are negative. But if you take a close history, the person's having a delayed response to exposure that I can show you in a minute. The other thing is the work history was often incomplete by some of my pulmonary colleagues. That is, if someone is listed um, as a warehouse distributor of tools, and that's what his job title is, and that's what he says he does. You take his history a little bit more detail, it turns out twice a week he's loaned to the paint department. And guess what? One of the symptoms worse in the days or evenings when he's in the paint department and not when he's in the warehouse. So the history, because people get multitasked these days, can be very tricky. And we know about the epidemiologic setting, other adults starting in the locker room saying they've been diagnosed with asthma at age 35 or 40 is very suspicious. And then there are variant symptoms. It's not always wheezing, but it's cough only, dry cough, nocturnal symptoms, recurrent bronchitis, nasal symptoms. Any adult that has recurrent bronchitis for no clear reason, should be suspect to have occupational related airways disease. Diagnosis, exhaled fractional NO is available in some labs these days. It's usually higher in patients exposed to the big molecular weight compounds than in those with lower, and I haven't found it to be useful in irritant asthma unless someone's having an exacerbation. Sputum EOs are going to be negative in irritant asthma. They correlate well with FeNO levels in adults and children. But it's, again, mostly those classic high molecular weight animal plant-derived proteins. So I wouldn't go out of your way to the time and expense to do that if you're trying to make a diagnosis. And again, blood eosinophilia and airflow obstruction are more frequent in those with the high molecular weight compounds. So the low molecular weight sensitized class is a little bit odd sometimes, and the irritant class is totally different from both high and low molecular weight. So again, you should consider this diagnosis in all adults with new asthma, have any work-related symptoms, or worsening asthma after a long period of quiescence in their known asthma. And of course, exposure is key for us. Unfortunately, asthma is a syndrome. It's not a simple pathologic diagnosis. So you can have many other syndromes that have to be ruled out, eosinophilic bronchitis, VCD. This patient had VCD too. Let me say something about VCD. So VCD, as you know, has been described as pseudoasthma in the literature in people who have pure VCD and negative airway workup. However, flip this around, asthmatics are more commonly suffering from VCD than non-asthmatics. So you may have to treat both conditions, as was the case here. Secondly, VCD is not that easy to diagnose. A standard ENT scoping is not good enough. This case sounded good. The ENT person has to be attuned to what you're looking for, and they need to use a strobe light to look for paradoxical motion of the cords. Without the strobe light, they can tell you if there's erosions that look like from GERD, they can see swelling, they can see cysts, but it's really hard to do it well without using a strobe light. And of course, most patients with VCT will have hoarseness, not just their other asthma or asthma-like syndromes. Symptoms, cough, wheeze, intermittent chest tightness. But do work with an ENT who's willing to do this, particularly if you have a high suspicion for it. And they should respond to speech therapy, as this person did. Of course, upper respiratory tract irritation, nasal sinus problems, laryngeal problems, all can appear to be like asthma, polyps, and all kinds of upper airway things that patients describe as coming from their chest, but on careful exam turn out to be upper. need to be ruled out and then need to be treated because they're a source of morbidity in and of themselves, even if asthma has been ruled out. HP does not usually overlap with asthma. Some cases of acute HP can wheeze and they'll need bronchodilators, but that's really a sensitized, a latency period disease with documented pneumonitis, and in the early stages are very steroid responsive. It's underdiagnosed. We should have a higher index of suspicion, but it wouldn't be in a case like we saw today. It doesn't have the kind of periodicity of symptoms. It's just a negative HRCT. And then, of course, psychogenic factors, which are quite complex. And all of these conditions can coexist with asthma, can overlap with asthma. And so that's what makes airways and asthma treatment so complicated in the workplace sometimes. So management and treatment, no surprise to this group. With those who are sensitized, they just can't be exposed anymore. Rare to have immunotherapy work. I think I had one scientist who was out in the field a lot, environmental scientist and bee sting allergic. So she underwent bee sting immunotherapy because it was really dangerous for her to be out in the field, even with the proper clothes. That worked, but they're not available and not effective for most workplace situations, certainly not for low molecular weight compounds and obviously not for irritants. So with irritant asthma, we're going to reduce or eliminate exposures. But in anyone who has established asthma, as in this case, they need to be monitored closely, helped out with their work placement or compensation, and consider any intervention for other workers. In this case, this is a little bit tough, but obviously cops are not trained the way firefighters are to respond to fires first. It's hard for them to probably just stand by and watch something, but they're, in this case and some others, they respond like civilians, trying to rush in and help without the proper treatment or equipment. And so I think that's kind of obvious what prevention would be here, in terms of protocol for responding to a fire, and have the firefighters do the work they're trained to do and with the right protection. So in all cases, we optimize med treatment and try to reduce triggers, of course. The pharmacologic treatment in this situation is similar to our non-occupational asthma and non-irritant asthma for that matter. The pyramid's changing a little bit. So in general, we started with beta agonist, PRN, then ICS, and then LABA, ICS, long-acting beta agonist. In the past 24 months, this pyramid has changed. I don't think it would change the care in this person's case. She's doing really well with only the occasional beta agonist. But now, some of you have done some primary care work as well. LABA and ICS are at the top of the pyramid. And rescue inhalers are really just in the pocket. They should not be actually used except truly as a rescue. And they're using LABA and ICS as PRN. Seems counterintuitive to everything we were taught, but it was a big trial done in 2024 and published in JAMA, and it's changing recommendations, although insurers and pharmacy coverage do not recognize it yet, so you can't prescribe it quite like that. They have people do 1 to 2 puffs PRN for even a long-acting ICS that was only 1 puff twice a day. And after a 3-month trial, thousands of people, those with the PRN approach used 20% fewer puffs and had 20% fewer exacerbations than those who were on the fixed dose LABA ICS with PRN beta agonists. So just keep that in mind. It'll be hard to write for those now. They get kind of automatically bounced when you do a computer, but you can tell the patients they can use it more. If they're not used to doing it that way, then leave them be. But for new and younger patients like it because they just do a PRN. Leukotrienes, muscarinics, and of course oral steroids. Like in this case, she needed it once. Biological agents usually usually not high on the list for irritant asthma because you have to meet some other criteria for them, like IgE and eosinophils. Not sure they'll have a role because they're so specific in the pathways like IL-4 and eosinophils that probably don't have any role in irritant asthma for the foreseeable future unless we're missing some off-label benefits from those things.
Dr. Christiani.
Prognosis, early intervention is critical, of course, and cessation of exposure. And negative prognostic indicators are lower FEV1 at diagnosis, degree of hyperreactivity on methacholine, and of course, continued exposure. That's true for all asthma. Okay, I can end there for questions.
Great timing,
Um,
and thank you so much for the talk. I think actually Dr. Goldman had a couple of questions regarding, and
okay.
I believe you did address it. The first part of it regarding the chronic inhaled steroid slash LABA for management of particularly irritant-induced asthma, and then a follow-up question regarding, potential for better exercise tolerance with
Hmm.
management.
Hmm. I'm sorry, the second question was about exercise.
Exercise tolerance, yes.
Oh, yeah, I mean, in case I think Susan really managed her well. I think it's basically as tolerated. There's unless exercise is a specific trigger, which it's not in this case, her she feels she's not at her best, but that doesn't mean she's having triggers. She's just not at her best. And she maybe some of that can be subjective because she's so fit. It may be hard to see um, small changes that we would consider abnormal. But if someone says they're running in sub-zero weather and having trouble, it's probably, of course, the temperature is going to be a problem. But I think it's just PRN and more exercise, the better, as far as I'm concerned. Just not when there's smoke around.
Fair enough. And I think actually Dr. Upham had a question as well, asking whether or not you could discuss further when to choose oral steroids versus
Yeah,
inhaled, and which to use first.
yeah. I'm pretty conservative. I really think oral steroids, they're wonderful when you really need them, but they're terrible if unless you really do need them. They're just not something you want to do unless it's necessary. When it is necessary, we move towards very short courses with established asthmatics who have a trigger. They're usually the sensitizer asthma community-based, but that would work for occupational too. If someone has an exacerbation, we may put them on, 4 days, 5 days max of 40 milligrams a day with cold turkey, no slow tapers anymore, none of that crap. There are even some trials coming out, like I keep thinking, even though they're totally different mechanisms, a little bit like antibiotics, very short courses of antibiotics now, if you notice. three
Mhm.
days for acute bronchitis. Well, steroids probably pretty similar. We're getting down to like how low can you go on the limbo stick? Because it's for side effects, it's for a lot of things, for bacterial resistance. So yeah, it should only be someone who really has a serious enough attack. They're not responding to rescue, not responding to PRN, LABA, ICS, which is a lot of potential meds. If you're using that 8 times a day as opposed to the once or twice that it was originally prescribed for, then they're failing and they need a boost. And it should be documented, of course, if you can with peak flows or spirometry. I can't tell you how many people come to the clinic a little bit tragically, chronic steroids, chronic low dose steroids with all the sequela of steroid complications and probably none of the benefits because they're at like 5 or 10 a day. Obviously, we know some room conditions they need to do that. But these are people who are diagnosed with asthma or asthma, and they come in and they get them off. It's painful, but get them off soon. I might start every other day, double the dose, put it on every other day, make sure 0 days are starting to get their cortical stimulation back to normal and some muscle mass or whatever. Then start getting them off every other day off to zero as soon as I can. And it can be a struggle. It's patient management. They'll fight with you sometimes, but they'll feel better at the end. Their sugar, blood pressure, everything, weight will be much better. And so this can be a big management issue. But oral steroids really, it's an emergent sort of thing. Well-established asthmatics should have a prescription for it. They should know how to use it. And they should be able to start it without calling you. That's really a well-established asthmatic who's been through this before. So it's both liberal on one side and more conservative on the chronic side. Does that answer your
Excellent.
question, Susan? Yeah.
Yes, that's great. Thank you.
Perfect.
Jeremy has a question. Great,
Hmm.
wildfires, WTC, what early signs? Early signs, well, that's a good question. Since these episodes, like World Trade Center attacks, wildfires, um, well, the World Trade Center was so unanticipated, it's kind of hard to know what to do early, other than everyone overexposed in that situation. Well, the FDNY already had a program, so they were already in a surveillance program. So they didn't just sort of wait for them to come back with symptoms. They were in a surveillance program right from the get-go, which is great. Wildfires, they need to do more stuff like that. Jumping versus stationary firefighting is a very different thing. They're younger and much more fit, and they can be pretty cowboyish about all this stuff. I think that whole culture needs to change as far as not just their pre-placement physicals, but having them recognize sign. They just have to get better at reducing exposure. I think a lot of times they're not able to wear or want to wear protective devices as long as they probably should be. And I think that's a big challenge compared to our stationary structural firefighters who are really well trained in this stuff. I mean, I haven't seen a hazmat incident like this police officer had in a firefighter like in years, like almost never. It's been like 20 years since I saw any firefighter have what she had, at least in the region I'm seeing. So unanticipated problems are a big issue, but wildfires are really a different ball game. You're obviously not going to engineer those exposures out. So there's going to be much more reliance on PPE. I mean, that is for structural too, but they know what they're doing and they know it's like finite. Hour 1, hour 8, it's over. Wildfires are out there for days, weeks, months, and it's like rotating. And I don't have an answer for that one. That's a tough one. That needs some really creative occupational medicine, occupational hygiene. Yeah, Rose makes a good point. A lot of people in WTC also rushed in without proper protection. This is 25 years ago, and there was a lot of controversy about it at the time. And I think that probably did contribute to those who were down town versus those who were in place, who were the control group when the FDNY did the studies I'm talking about, the follow-up study. It was a natural experiment. They paired them with those in place uptown, downtown. And you're right. If they followed the usual hazmat, you would think we would have seen less. We could always ask David Prezant that when you see him at a meeting from the FDNY. But I think you're right. There was a lot of controversy about it. And that probably a lot of airway problems could have been prevented if they followed their usual sort of hazmat, or at least um, uh, respiratory protections they would to run into any burning situation and the smoldering that took place afterwards. So the subacute. Thanks, Rose, for bringing that up.
Dr. Christiani, it's good to hear from you again. Good to see you again.
You too.
Will I get to see you next week in DC?
Yeah, I'll be there.
Well,
I'm going down tomorrow. Yeah.
I have two questions for you. One, kind of clarifying the difference between the physiological response to smoke exposure versus larger particular position in the
Yeah.
lungs. And then the other one is we'll get to that. But yeah, could you clarify for me, the physiological response to smoke is much different to like, PM 2.5, PM 10 with particle deposition. Could you
Yeah.
kind of clear that up?
Well, the best I can. So there's a distribution of exposure components in smoke, and they do range from, as you implied, pretty coarse with incomplete combustion that can be quite fairly large that get trapped in nose, sinus, perilaryngeal, and trachea, and perhaps down to the large bronchi when they're like, say, PM 10 below 15. Then you get this other, so you look at distribution, the size distribution goes, as it gets smaller, it gets deeper and deeper into the lung, where PM 2.5 can get all the way down to alveoli, respiratory bronchioles. So you get this whole mix from those stuff that can get trapped in the upper respiratory tract, virtually exclusively, the real big particles, the rocks. But then as you move to PM 10, you have a tracheal fraction that's pretty high there, but not so much an alveolar fraction. So it's a really complex, Christopher, because you got all these particles, and then you also have gases in there too. And the solubility of the gas will depend on where they go. And the gases themselves can absorb onto some of the carbonaceous particles, sulfur, and get carried down with the particles. It's an incredibly complex exposure. But step back and think about cigarette smoke. I did a lot of work on welding fumes, and I was surprised that welding fumes had a distribution. It wasn't that dissimilar from cigarette smoke. very fine, very fine smoke with a lot of ultrafine. That means even less than 1.0, and even back into the so fine is like 2.5 to 2, and then ultrafine is like to 1.0, and then nano below zero point 0.1. It was all represented in welding smoke and cigarette smoke. Cigarette smoke was the best example. It was very fine because it's meant to deposit as deep as possible. Welding fumes, some of the metal particulates will agglomerate. They start out fine, then they get bigger, bigger, bigger. By the time you breathe them in, they're too large to get down too low. But cigarette smoke was like, if you were the devil wanting to design the best thing to get into the pulmonary circulation and all the way down to the alveoli. So it hits circulation all the way down the bronchial circulation, then right to the alveolar surfaces, and then into the bloodstream. It's a you don't get agglomeration with those. It's fine, pretty much fine to ultrafine to nano in cigarette smoke. But this stuff is welding's in between the two, smoking and then this kind of burning. And the burning thing, as you know, with the temperature varying quite a bit, you can get some pretty coarse particles, like when you saw in the ER and people with soot in their throat and stuff. That's not going to get to the lung. And the temperature will decide whether there's burning in the upper tract. But the particles are too big to get lung. But what you're not seeing is and it's not always normal. It depends on what the distribution is. Assume it's normal. You're going to have some pretty fine, ultrafine stuff in there, and that's going to get really pretty low into the lung. Concurrent. So some are being trapped and filtered, some are going right down to the lung.
Yeah, so
That's how you get the CO poisoning too, right? The CO is a gas. You can have a very coarse fire, it's the stuff, but if you're in a closed space, you get quite a bit of CO because of the incomplete combustion.
so it really is just kind of a comprehensive
Yeah,
swipe at your entire respiratory system down to the
yeah, which starts at nose, does not start at the trachea.
understood. Well, thanks for clearing that up. The,
Thank you.
the other thing that I wanted to ask you is there, I've read some studies over the last 5 to 10 years that have come out that relate the perceived risk or stress levels. And I think this was in children. It's the childhood asthma study. Um, the risk, the stress, the perceived risk, and how that it kind of tracks very parallel with their asthma severity.
Yeah,
Now, I wanted to ask, is that being considered now in, treatment plans clinically? The environment,
yeah, it's very good.
household, the
Yeah, good
neighborhood?
point. Good point. I mean, stress we know is a trigger to asthma, so it's on the list as it is to angina, but we don't do a good job managing that as a trigger. You tell patients manage your stress, but it is for well-established asthma in kids or adults, it is a well-described trigger, and I think we're not well equipped to manage it well because I think sometimes trained as MDs, we tend to think about pharmacologic treatment and we're not comfortable giving people psychoactive drugs, especially if they have to work and get urine tested. But I think the answer to some of that's going to be not in our medical bag, but it's more like CBT and stuff like that, behavioral therapy
Okay.
with non-MDs, but people and don't need to use drugs, but can do cognitive behavioral therapy stuff. And they're, I guess, making most of their money doing people, I think, are getting older and cognitive decline. But I think it has a role in things like this and probably a bigger role than we've been able to, ascribe to them. And they can probably do a better job that we can. Rose is talking about biofeedback, which I think is really kind of I think as a non-psychiatrist, as a offshoot of CBT therapy and stuff, cognitive behavioral therapy and feedback. And I think it can be very helpful. I think it can be helpful in pain syndromes and asthma and a whole bunch of things. We just don't know how to get our heads around it sometimes as physicians, but I think that's a really good point.
Well, it's interesting to hear where just that approach lies in terms of the whole
Yeah,
spectrum of treatment.
yeah. Well, I think if you have someone whose parameters are really normalized and you want to have them avoid overusing certain meds, including the LABA ICSs, which are very expensive, have their share of side effects, but long-term use with cataracts and things like that. It would be nice if we can get them to move to non-pharmacologic. I think that's what you're getting at, some non-pharmacologic treatment long-term. Definitely, I'd be all for it. I just wish we had bigger group of colleagues in the CBT world who specifically started to think about occupational settings or about these kinds of settings that they can be there for us. And I suspect that has to do with reimbursement and a lot of other things like that. But I'm totally with you on that. But yeah, I have sent people to it. It's just hard to get them in. I want to get their drugs not abuse, but get their medication use down. The time to see, how many times to see physicians down, how many unanticipated, all the things drive up costs and cause absenteeism and stuff. I think they can benefit by things like that tremendously. They just don't want to be told they're crazy.
Yeah.
But the biofeedback CBD people are pretty benign compared to a shrink usually. So.
Well, I need to be told I'm not crazy. All right. Well, thank you again very much. I really enjoyed that.
Thank you, guys. Good to see you all. Hi, Bruce.
Well, thank you. Thank you everyone for being here. Kevin, feel free to add as well.
I, I think this was a fantastic lineup of presenters. I think we got a wide variety of perspectives on things that kind of link us from an interdisciplinary approach. So, um, you know, really appreciate everybody being present and, asking great, thoughtful questions and sparking discussion. Hopefully this is something that we can replicate year after year.
Yes, definitely. Thank you, Kevin. I appreciate all of you joining us on a Saturday too, spending a half day into our speakers for outstanding presentations. So thank you all.
Enjoy your weekend. Because you are all released now.
Yes.
Big thanks to our crew in putting this together, as well as our speakers.
Yes. Thank you, Chris and Keith and everyone. Yes.
Absolutely. Thank you both.
Take care, everyone.
Thank you.
Thank you.
Take care, everybody.
Bye.